Namaste Vidya, Hamisha Khush Raho Vidya. A very good morning to you all. Myself, JB and Dr. Ravi Jain, Assistant Professor, Department of Medicine, Faculty of Science, JAYOTI VIDYAPEETH University. In the series of respiratory system, today we are going to discuss about bronchiectasis. Bronchiectasis is an irreversible airway dilatation that involves the lungs in either a focal or diffuse manner. There are permanent dilatation and distortion of the bronchi. Classically, it has been categorized as cylindrical or tubular, the most common form, varicose veins or cystic. These are four types: normal, cylindrical, varicose, cystic. What is the etiology? It can arise from infectious or non-infectious causes, which can be focal bronchiectasis or diffuse bronchiectasis. Focal bronchiectasis refers to the bronchiectatic changes in the localized area of the lungs. Diffuse bronchiectasis is characterized by widespread bronchiectatic changes throughout the lungs. The focal bronchiectasis is from obstruction, and extrinsic obstruction by either intrinsic factor or extrinsic factor. Extrinsic factors example due to the compression by adjacent lymphadenopathy or parenchymal tumors. Intrinsic factor example due to the airway tumor or aspirated foreign body, a scarred or stenotic airway, or bronchial ectasia from congenital underdevelopment of the airway. The diffuse bronchiectasis from underlying systemic or infectious disease process. The involvement of upper lung fields is the most common in cystic fibrosis and is also observed in post-traduction fibrosis. The predominant involvement of the lower lung fields usually has its source in chronic recurrent aspiration, end-stage fibrotic lung disease, or recurrent immunodeficiency associated infections. The mid-lung fields resulting from the infection by non-tuberculous mycobacteria, most commonly the Mycobacterium avium intracellular complex and AC complex. Congenital causes of bronchiectasis with predominant mid-lung field involvement include dyskinetic or immotile cilia syndrome. In many cases, the etiology of bronchiectasis is not determined and is called as idiopathic disease. The epidemiology. The epidemiology varies greatly with the underlying etiology. The incidence of bronchiectasis increases with age. Incidence is higher among women than in men. High incidence of malnutrition in certain areas may predispose to immune dysfunction and development of bronchiectasis. 25 to 50% of patients with bronchiectasis have idiopathic disease. Pathogenesis, the vicious cycle hypothesis. Susceptibility to infection and poor mucociliary clearance results in microbial colonization of the bronchial tree. Pseudomonas aeruginosa exhibit a particular propensity for colonizing damaged airways and evading host defense mechanism. The classical studies demonstrate a small airway wall inflammation and larger air wall destruction, as well as dilatation with loss of elastin, smooth muscle, and cartilage. The ongoing inflammatory process in similar ways results in airflow obstruction. The pathogenesis, bronchiectasis, and emphysema have been observed in patients with alpha-1 antitrypsin deficiency. Mechanism for non-infectious bronchiectasis includes immune-mediated reactions that damage the bronchial walls, example those associated with systemic autoimmune conditions such as Sjogren's syndrome and rheumatoid arthritis. Traction bronchiectasis refers to dilated airways arising from parenchymal distortion as a result of lung fibrosis. Example, the post-radiation fibrosis or idiopathic pulmonary fibrosis. The clinical manifestations. It consists of persistent productive cough with ongoing production of thick tenacious sputum. The physical finding often includes crackles and wheezes on the lung auscultation. Some patients exhibit clubbing of the digits. Mild to moderate airflow obstruction is often detected on the pulmonary function test. Acute exacerbations are characterized by increased volume and purulence of sputum production. Typical signs and symptoms of lung infections such as fever and new infiltrates will not be present. Approach to the patient. Elicitation of clinical history, chest imaging, and a workup to determine the underlying etiology. The bronchoscopy to exhibit airway obstruction by underlying mass of foreign body in the fluid bronchiectasis. Pulmonary function test, bacteriological and mycological examination of sputum, assessment of ciliary function. Diagnosis. Persistent chronic cough and sputum production accompanied by consistent radiographic features. Chest radiographs lacks sensitivity and the presence of tram tracks indicating dilated airway is consistent with bronchiectasis. Chest computed tomography is more specific. CT scan include airway dilatation, detection as parallel tram cracks, or as the sign of signatory sign. A cross-sectional area of the airway with a diameter of 1.5 times that of the adjacent vessels. Lack of bronchial tapering, bronchial wall thickening, or cystic emanating from the bronchial wall. This is the signatory appearance. Management. How to manage such a case? Control of active infection, improvement in secretion clearance, and bronchial hygiene, and to decrease the microbial load within the airways and minimize the risk of repeated infection. Other part of the management include antibiotic treatment. This is the pharmacological part. Targeting the causative organism or presumptive pathogen, that is Haemophilus influenzae and Pseudomonas aeruginosa. For Pseudomonas, oral ciprofloxacin or cifotenamide. Ceftazidime by intravenous injection or infusion may be required. Bronchial hygiene to enhance the secretion clearance, hydration, and mucolytic administration. Regular daily psychotherapy to assist the drainage of excess bronchial secretions. Surgical treatment. The excision of bronchiophletic area is only indicated in a small portion of cases. Now the prognosis. The prognosis varies widely with the underlying etiology and may also be influenced by the frequency of exacerbations and specific pathogens involved. In the disease is progressive when associated with severe dysfunction and cystic fibrosis and eventually causes respiratory failure. The prognosis can be relatively good if the physiotherapy is performed regularly and antibiotics are used aggressively. The complications. In severe cases of infectious bronchiectasis and recurrent infections, microbial resistance to antibiotics may develop. Recurrent infection can result in the injury to the superficial mucosal vessels with bleeding and in severe cases life-threatening hemoptysis. Prevention. Reversal of an underlying immunodeficient state by administration of gamma globulins. Vaccination of patients with chronic respiratory conditions by influenza and pneumococcal vaccine. Homeopathic management consists of ammonia, antinetat, Balsamum peruvianum, Calcarea carp, Pupavia, Percel, Tenofacron, Riozotum, Medorrhina, Pertussin, Philendrium aquaticum, Phosphorus, Sanguinarium nitricum, Stanamac, and Tuberculina. Balsamum peruvianum consists of bronchitis and phthisis with much purulent, thick, creamy expectoration, loud rales in the chest, very loose cough, hectic fever, and night sweats with irritating, short cough, and scanty expectoration. Pupavia consists of cough with profuse, gray purulent expectoration, tickling in the larynx, trachea, and bronchi. Bronchial catarrh with profuse greenish offensive discharge. Philendrium aquaticum. Dyspnea and continuous cough early in the morning. Cough with profuse and putrid expectoration compels him to sit up. Sanguinarium nitricum. Short, hacking cough with expectoration of thick, yellow, sweetish mucus. Sternum metallicum. Much mucus is expelled by forcible cough, violent, dry cough, and evening until midnight. Cough is excited by laughing, singing, talking, words lying on the right side, and during the day with copious, greenish, sweetish expectoration. So this was all about bronchiectasis. In the next topic, we will be discussing about pneumonia. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my session. If you have any query, please mention in the comment box. I'll try to resolve it. So this was all for today. Thank you.